بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Thank you.
Next slide.
So yesterday and today we heard a lot about the breakthrough and exciting time for many genetic treatment. One of them is spinal muscular atrophy, as you know, and we used before when we diagnose a baby or a child with spinal muscular atrophy, we used to sit with the family, we give them, unfortunately, the bad news, the diagnosis, and we tell them there is no treatment available. Now I think the paradigm change and the natural history of spinal muscular atrophy dramatically changed. Now we sit with the family, we give them the diagnosis, but we give them good news that this is now a treatable condition. Actually, there are currently, as you know, 3 approved treatment for spinal muscular atrophy. One of them is Evrysdi. The other treatment is nusinersen, which is an intrathecal treatment, and also there is a gene therapy treatment. But still we have challenges in spinal muscular atrophy. Dr. Omar mentioned about the early diagnosis, and I think for all genetic and metabolic disorders, early diagnosis is crucial. And I think whatever we do, unless we include these disorders in the newborn screening, still there will be a diagnostic odyssey. So spinal muscular atrophy, I think it's a perfect disease to be included in the newborn screening program. Other challenge is the access to the treatment. So accessibility to the treatment. We know all these treatments are expensive, so it's not granted, and the access is a challenges. But today I will focus on Evrysdi or Risdiplam for treatment of spinal muscular atrophy. And you can see from the name Evrysdi. So Evry is this oral drug can be used for all types of spinal muscular atrophy, meaning type 1, type 2, and type 3, and almost for all ages, starting from 2 months and older. So a few words about spinal muscular atrophy. I know the audience know about SMA, but SMA as a neuromuscular disorder characterized by neonatal or early hypotonia. So you should now include spinal muscular atrophy more when you have a hypotonic child. Also characterized by progressive muscle weakness and atrophy. And again, this is the natural history of the disease. And this leading to a degeneration and loss of anterior horn cells in the spinal cord. That's why typically we see, especially neonates, infants with spinal muscular atrophy, usually they are alert, interactive, but they cannot move. And this is what makes it difficult for the family when we used to counsel them that this is a lethal condition. Because usually they have normal IQ, they have normal cognition. And it's one of the commonest causes of infant morbidity and mortality, especially here in our region. Maybe internationally and worldwide, maybe cystic fibrosis come as #1, but here in our region, SMA is the most common lethal genetic condition. And talking about genetic of SMA, what is the etiology of SMA? It's a bit complex, but we'll try to make it easy together. So here, as you can see, we have 2 genes for SMA. So the main gene is SMN1, and this is in the 5q13.2. in the terminal part, and we have a backup gene, which is SMN type 2, which is a backup gene. Usually I explain it to the family that these two genes, the main gene is SMN1, just like if you have boss or managing or manager. So this is the main gene, right? So if there is any deletion or any mutation leading to non-function of this gene, means you have SMA, full stop. But what is the role of SMN2? SMN2 as a backup gene, and usually I explain it again to the family as if you have an assistant to the manager or maybe secretary, right? So of course it can do some work, but it cannot sustain the work of a company or and you can imagine the more copies of SMN2 means, having more assistant or more secretary in the absence of the manager, the more milder the disease, so work can go. So this is normal individuals. Usually normal individuals, they have 2 working copies of SMN1. And if you have only 1 working copy of SMN1, this is what we call it carrier. And carrier frequency worldwide about 1 in 50 to 1 in 60. However, in our region here, in one study from Saudi Arabia, showed carrier frequency of 1 in 20. So you can imagine how common SMA. So what happens in affected individuals or affected baby with SMA? You have the 2 copies, either you have deletion, as I said, or you have mutation. And worldwide prevalence and incidence is 1 in 6,000 to 1 in 11,000. However, I'm just, from our clinical experience, I'm suspecting the prevalence here 1 in 2,000. And I think this is by all means make SMA eligible to be included in the newborn screening programs. So again, I mentioned this already. So what happens in SMA, and really this is important because this will make it easy when it comes to the medication, to the available medication, how it works. So as I mentioned that we have SMN1, this is the main gene, and why is the main gene? Because it produces a healthy and full-length messenger RNA, and also messenger RNA translated into a 100% functioning protein. While SMN2, the backup gene, because there is difference in one nucleotide from C to T, there is exclusion of exon 7. So the only difference between SMN1 and SMN2 in exon 7. So if you exclude exon 7, you have non-functioning messenger RNA, and also you have only maybe 10% or maximum 15% of a functional protein. So here, as I said, the more you have SMN2 copies, the more you have a milder phenotype, and the more you have more effect of the treatment that work on SMN2. So this is what happens in SMA patients. You have non-function, deleted or mutated SMN1, and then mainly patients or individual will rely on the SMN2 genes. And this is how Evrysdi work. So Evrysdi is or Risdiplam work on SMN2, nothing to do with SMN1, and lead to the inclusion of exon 7. So basically, you are transferring SMN2 to SMN1, more or less. And if you include exon 7, so you have a full-length SMN messenger RNA, and then you will have a fully functioning protein. And I think now, without saying, the early you introduce the treatment, more you will have a functioning protein and more you have outcome. Again, here more, because the other treatment which I mentioned, nusinersen or Spinraza, it's also work on SMN2. Only the gene therapy which replace SMN1. But what is the advantage of risdiplam or Risdi? Because risdiplam, it works in two methods to include exon 7. So this approach, we make sure that all exon 7s will be included in the SMN2. So it works by acting in the 5' splice site of intron 7, as well as in the exonic splice enhancers. So this way you will have more functioning SMN protein from SMN2. And in terms of development for risdiplam, there are several clinical trials and all called FISH program. I don't know why they call it FISH, but it's called FISH program. And it included about 450 people with different ages. And this is the only clinical trials different from other medication where they included patients or individuals more than 18 years. So this is included individuals up to 60 years old. And as you can see here, risdiplam or Risdi approved in August 2020. And it's the first treatment for SMA to be taken orally. So it's very convenient for the patient and also different from nusinersen because it has a wide distribution because it's taken orally. It goes to, of course, our target, which is the brain and spinal cord, but also will go to other tissues, for example, like muscles. So also can have effect in muscles. And as I mentioned, this is the different clinical trials. And as you can see here, start from a pre-symptomatic trial to type 1 SMA. This is called Firefish. Will include infants from 1 to 7 months. And sunfish, which include type 2 or type 3 from 2 to 25 years. And also the third one, which is jewelfish, which include patients from 6 months to 60 years. So all these are naive patients. They don't receive or they didn't receive any treatment before. But for jewelfish, this is patients recruited who already in other treatment or received other treatment. So this will be very interesting data from this clinical trial. So if we're talking quickly about different trials, so as I said, Firefish is for infant from 1 to 7 months. And this is including SMA type 1. And we know SMA type 1, usually we call it non-sitter. So infant or babies, they don't sit and it leads to a progressive disease, either end up by permanent ventilation or unfortunately they die. And what is the outcome from this trial for SMA type 1? So by 12 months, so the primary endpoint is sitting without support for 5 minutes, for 5 seconds at least. And this will never be achieved for SMA type 1 patients. Additional endpoints include permanent ventilation, include achievement of other motor milestones, include feeding, include swallowing, and include admissions to the hospital. So this all are secondary endpoints. And you can see this is the outcome from this study. About 29% of patient enrolled, they were sitting without support for 5 seconds. This will never be achieved in natural history. Again, it leads to a significant improvement in other motor functions. It leads to improvement in swallowing. Again, about 93% of individuals included or babies included, they were alive, and only 85% of infants were event-free, means no permanent ventilation. And this is the reported side effects. You can see, for example, upper respiratory tract infection, constipation, diarrhea, because as you know, it is taking oral, but none of these side effects lead to the withdrawal of any infants from this trial. The second clinical trial quickly, which is Sunfish, which include patients or individuals with type 2 and type 3 aged between 2 and 25 years. And again here, in the part 1, about 51 patients, and in part 2, about 180 patients. And in the outcomes here, as you can see, there is improvement in all motor scores at 12 months between patients and placebo group, those who received the treatment and the placebo group. And this is the side effect, and you can see here, there is no much difference between those who received risdiplam and those on placebo, means that most of the adverse events related to the underlying disease rather than related to the medication. And the outcome, 100% survival, and 100% of the patients, there is no drug-related safety leading to treatment withdrawal. So almost all patients or individuals continue clinical trial. So as I mentioned, the medication is the only and first medication to be taken oral, so it's very convenient for the patient, especially those who have challenges. For example, either they are not eligible for gene therapy, or for example, they have challenges like severe scoliosis, and they cannot receive the intrathecal medication. So the dose from 2 months to 2 years is 0.2 milligram per kg. Daily dose taken orally, preferable to be taken in the same time. For patients more than 2 years, if it's less than 20 kg, it's 0.25 per kg. If it's more than 20, is a fixed dose, 5 milligram daily. And this is how to calculate. Our experience in Qatar, we have 7 patients treated with risdiplam or Evrysdi. This is our pediatric cohort, so we have 4 patients treated as of July 2021 last year. This is some data. All of them, they were on nusinersen from 2017, and they were switched to risdiplam, basically based on our recommendation as well as the family request, because as you said, it's oral. We had some challenges into giving intrathecal medication, and also during COVID pandemic, most family either they refused or they want to avoid coming to the hospital and receive nusinersen. And we have 3 adults with type 3 SMA also. In the last 3 months, they switched from nusinersen to risdiplam. So conclusion, I mentioned that Evrysdi for everybody, it's SMN2 splicing modifier, taking oral for all patients more than 2 months or older, and it's a daily dose. And thank you very much for your attention.